Hello, RCH CE event. We're very happy to have you here, this virtual event. We've got a power-packed lineup tonight, and what's interesting about tonight is it is cases that you sent to us. So these are actual cases referred by Houston eye care specialists, optometrists that really, through our HIPAA-compliant web portal system, that really, involves interaction of patient care and maybe research and all these things. So 5 of our doctors will sort of go through the different cases and really look at them tonight. So Dr. Binns, Dr. Brown, Dr. Chin, Dr. Fish, myself, I'm James Major, and Dr. Shaw, Dr. Wyckoff, and lastly, Sagar Patel, who is our new physician that starts in about a month here. He is also on the call, and he'll be first to go. So we're very happy to welcome him to Retina Consultants of Houston, Dr. Patel, and you'll hear from him tonight. But we're excited to have him with us as a new physician. And so, of course, this virtual CE is sponsored by the Greater Houston Retina Research Foundation. Of course, it's a 501c3, it's a nonprofit. This is completely separate from the finances and interaction of Retina Consultants of Houston, the clinical entity. So that is who is sponsoring us tonight. And that is our research arm that drives, our research foundation that drives our research and to get the best patient care we possibly can. So again, they are sponsoring this tonight, Greater Houston Retina Research Foundation. So, let's see, let me whip through here. Let me catch up, full screen, there we go. Offices, many of you are familiar with all our offices around town. You can see it from the map. I'd like to highlight the new Pearland office. So the new Pearland office opens in later September, so about a month or so, and it'll be just outside the Beltway on 288 South. So we're excited to have that new office open on the south part of town, new Pearland office opening up in about a month or a little more. Again, many of you are familiar with it. We're not just any retina practice. Every office has the ability to treat patients with lasers, injections, essentially anything we need beyond a surgical case. And again, that's the address on Memorial Hermann Drive of our new Pearland office, which we're really excited about. And in addition to Dr. Sagar Patel that I mentioned earlier, also joining us will be Dr. Vi Nguyen. So we're excited to have Dr. Nguyen, who's actually not on this call, but we'll hear from her probably at our C event we'll have next month in mid-September, and have one in mid-October as well. So this is very exciting. And this is Sarah Barbatano's baby, essentially. This is our web-based referral system. So this is a HIPAA-compliant image portal where you can send and view your patient's clinical images back and forth to us instead of the old school black and white letters that you get or a fax that you get. This is color images on a computer, HIPAA-compliant, that you send to us, and we send the letters back to you. So to engage in this HIPAA-compliant referral-based system, you just visit the HoustonRetina.com register, the portal information. And if you look on the chat box now or shortly, we're going to actually put that web link up so you can just click on it and look. You enter your basic information and a password, and then Retina Consultants of Houston will confirm that registration. And then when you're seen or when our patient's seen, you'll actually receive our color pictures, OCTs, letters, anything we do. And again, it's a HIPAA-compliant electronic format that's done instantaneously. So we're really excited about the RCH image portal and this really neat technology that really no other groups have. And Sarah Barbatano in our group has worked hard on this, and it is fantastic. So please sign up for that. And again, the link is in the chat box. I'm very happy and excited to introduce our newest doctor and our newest CE attending. This is Sagar Patel. He trained in Dallas at the UT Southwestern for medical school, did his ophthalmology, stayed and did his ophthalmology residency there. And interestingly enough, his wife, I believe, is a first-year ophthalmology resident, also at Southwestern in Dallas. So he lives in Houston. She will live in Dallas. They'll go back and forth. And he is a current vitreoretinal surgical fellow at USC in LA. So Dr. Patel, welcome. I'm going to kick it over to you to start the first case and really kick us off here, Dr. Patel.
All right. Thanks, Dr. Major. As Dr. Major said, my name is Sagar Patel. I'm one of the newest additions to the Retina Consultants of Houston. And I'm really excited to be moving back to my hometown, Houston, and to be joining such an amazing group of physicians. I'm also really looking forward to working with all of you and getting to know you better, hopefully personally, as this pandemic comes to an end. So let me start by saying I'm going to be discussing a case that was referred by Dr. Nguyen, one of our optometrists. The patient's a 27-year-old patient who came in, saw Dr. Nguyen complaining of blurred vision in the right eye for about a month and flashes for about a week. A thorough review of systems at the time was negative. And as you can see, here's the fundus photo that Dr. Nguyen actually took and sent to us electronically through the portal Dr. Major was referring to. In the right eye, you can see that there are these whitish grayish dots that are located in the posterior pole, kind of scattered throughout. So the case I'm going to be talking about today is MUDS, multiple evanescent white dot syndrome. It's typically an acute onset presentation with unilateral blurred vision. Normally it happens in young to middle-aged females. They can present complaining of decreased vision, enlarged blind spots, temporal visual field defects, photopsias, and sometimes they'll have flu-like symptoms as well. The initial visual acuity ranges from 20/20 to about 20/30. And the good news for these patients is most of the time, about after 6 weeks, the vision does return to baseline. So on exam, what you're going to look for is you'll see these multiple small gray-white dots deeper to the retina, so at the level of the RPE, typically in the posterior pole. There's another exam finding, foveal granularity. This is a very characteristic finding. So if you see this, you really do start to think of MUDS, though it's not present in all cases. The way you really clench this diagnosis is through the FA. It has a very characteristic finding that you can see. So early in the FA, you're going to see this early hyperfluorescence, but the late FA is really what helps you out. You see the staining of these lesions in this wreath-like configuration, and you can see that here in this picture that there's these circles kind of scattered throughout. OCT can also be helpful, and mainly you're going to see some loss of the ISOS junction. And studies have shown that over time, the ISOS junction does restore itself as these lesions heal. The pathogenesis of this is really unknown. It's thought that some of these patients may have these susceptibility genes that predispose them to immune dysregulation, and maybe there's an environmental factor that triggers it, such as a viral infection. But as I mentioned, the clinical course is usually very good. Symptoms typically resolve in 2 to 4 weeks. They rarely develop complications such as CNV lesions. So our patient presented, as I mentioned, with decreased vision and flashes. Visual acuity in the affected eye was 20/50. We did an FA at the time when she saw Dr. Henry, one of our uveitis specialists. He found that the FA showed this wreath-like leakage, which is, as I mentioned, characteristic. She was given a 10-day course of prednisone, and she should be following up with us in a few weeks. What's great about us is that we do have 2 uveitis specialists, Dr. Kim and Dr. Henry, who are able to manage patients like this and other patients with different types of uveitic problems. And I'd like to end by thanking Dr. Nguyen for such an interesting case.
Fantastic, Dr. Patel. Any questions? And also feel free, remember the chat box is open and hot. So any questions that you don't want to verbalize, attendees, please, we have sort of doctors standing by to answer your questions on the chat box. But MUDS is always an interesting diagnosis. It's always nice to make the diagnosis. Sometimes it looks worse than it is, but fortunately the patients recover really, really well. So, yep, Dr. Brown, are you ready?
I hope I'm ready. Let me find out.
Let's go to Dr. Brown. We'll keep it moving. And again,
you know what? The case is from hung slides, and then I got my slides. My slides don't have the case.
Your screen. Share my screen.
So we have a case that a lot of you guys refer to us all the time, and it really saves people's vision. You catch macular degeneration early, you're gonna get the advances that we've worked so hard to make. And let's see, there we go, Dr. Tung. Boom, here we go. We're going to mine because I got some videos. So we'll do next. So you have a slide here and you see what we usually see, because the eye is really good at ignoring one-eye troubles. And this patient presented to Dr. Mulder with decreased visual acuity. You see that fibrovascular PED, that's the coronal vascular membrane with cyst on top. And to be honest, in this case, sometimes you can pull a rabbit out of a hat and save great vision. And sometimes it's too late, but at least they're in the system. And both you and our referring doc, Dr. Mulder, will be following that fellow eye like a hawk. Because in the first year after presentation, they got a 25% chance of this happening. The next year after that, 10%, and that goes on for the rest of their life. So this is wet macular degeneration. You all know about it. We've talked about what we do in terms of Lucentis, Avastin, Eylea, till we're blue in the face. But what I'm going to talk about is 3 things we have in our back pocket that we're working in research that excite me. So I'm going to share my screen here, and we're going to go. That's not correct. All right, I'm hoping you see a big screen that says KSI, right? Shake your heads. There we go. So we have 3 things in the pipeline that I'm really excited about. We literally have 15, and these are what I'm most excited about. This is a drug from Kodiak. It's essentially an anti-VEGF. And unlike other anti-VEGFs where we thought smaller is better, in other words, smaller is Lucentis better than Avastin, et cetera. This is the opposite. It's great big. It is 950 kilodaltons. Why does that help? It means that the drug can last 5 times longer in the eye than a smaller drug. And so we're currently in phase 3 trials with this drug. We think it's going to be out in the next year and a half. If you look at their preclinical data, this thing could easily last 4 to 5 months. Going to show you just 1 case, fluid goes away just like our other anti-VEGFs. And this is data presented 2 weeks ago, trying to show you fresh stuff, that in their big phase 2, which they will present for approval, the average patient needed 1.3 injections in 44 weeks. That's a lot less than what we give now. And this is called a swimming lane plot. You see that 92% of patients went longer than 3 months, 82% patients went longer than 4 months, 66% patients went longer than 5 months, and that's just with 1 shot in the eye. Pretty cool stuff. So what else do I got that's even more exciting than that? Port delivery system. This is a trial we're doing. We're the only site in this part of the world. We surgically implant this. How do we do it? Let me show you. Here's a video. This is Dr. Wyckoff. We laser the bejesus out of the choroid because there were some initial hemorrhages. This is like a sustained release device that we put in the eye. It holds Lucentis or a Lucentis equivalent that then works for a long time. And so here he is putting a blade into the eye. Here comes the implant. It looks like an inverted miniature lava lamp. It fits in without a suture. And then the tricky part is suturing this up, because the main complications have been extrusion and problems with this closure. So Charlie's doing a great job. Here, how long can it last? This is the phase 1/2. Mean time to first refill, 15 months. If you can have a 5-minute procedure that gives you 15 months being followed up in your office, not my office, I'm happy, you're happy, the patient's happy. The FDA wanted routine 6-month fills, and this data was literally presented a week and a half ago of the first trial with this for approval. Here we are at the approval date. They show no significant difference between monthly injections and this on OCT. What about visual acuity? A little drop at 4 weeks just from the surgery ends up the end, and it's equivalent. And so we think this drug is going to come out, this implant. And for your patients that need continuous ongoing injections, it may be a great answer. Only 98% of the patients didn't need a refill. They went 6 months. We think many can go more. Last thing I'm going to talk about, cool stuff, gene therapy. 1 injection into the eye, a virus that makes Eylea. Here's the clinical trial in AMD. Charlie presented this, Charlie Wyckoff, our own, at ASRS a week and a half ago. So this is fresh off the presses data. Here he shows we give a shot, we do the injection, and what happens. Here you look at protein. The higher the dose we give, the more protein we get. Protein is an active drug working to treat macular degeneration. Here's our data. The visual acuity maintains the visual acuity, maintains the OCT without injections. Here's what we call the swimming lane plot. 9 out of 12 patients, even though all these dots on the left side of the thing are injections, after they had the treatment, 9 out of 12 needed no injections, 1 needed only 1. They're refining the process, but this looks really promising for potentially a one and done macular degeneration treatment. Got any questions, or what should we do from, are we going on to the next speaker?
You hear me?
Dave, we had a question in the chat box about if there's curious about the pandemic effects on the FDA trials. Have you heard of any changes?
Yeah, so Charlie and I both work a lot with the agency. The agency is letting us do, an abbreviated visit. They just want to get the data in. We do think it's probably going to be a 6-month delay for most drugs because a lot of the parts of the country, our partners in New York, partners in California have had a lot more troubles. Research keeps going on. We're going to fight the fight against blindness. But there is some of the delay is patients are obviously worried about coming in. In our clinic, we've been able to pay for limos that bring them in a private car, with everything wiped down and keep the visits going. In places like Long Island, most of the place was shut down for 3 or 4 months. So.
Thanks, Dave. Anchor. And also, Dave, quick question that Charlie actually already answered on the chat box, but you went over wet macular degeneration, but diabetic macular edema and diabetic retinopathy are similar style trials coming down the pike.
Yeah, Charlie's going to go over that. He's talking about some of the same stuff. I don't want to steal his thunder. So.
Sounds good. Okay. Dr. Shaw?
All right. So, I always have the job of talking about the bread and butter after Dave gets to talk about all the cool things like gene therapy. But anyway, here it goes. This is what you see more often. This is a case sent in by Dana Howard. And so Dr. Howard took this photo. This is what was submitted through the portal. And here's what we see. Let me see if I can pull that up. So here you can see a small tear, if you look closely on the temporal aspect of the right eye. And then if you kind of track it, you can see a little bullous area of fluid. So it looks like a tear with an early retinal detachment. This was a young patient in their 30s. And so relatively young with this change. So what are some of the considerations that we think of in terms of, one, from our perspective, but also from your perspective in terms of a referral? So there's a few things I think to think of. So one is the urgency. In this type of case, typically we're looking at same or next day. And sometimes you'll hear us say, have the patient come the next day with nothing to eat or drink after midnight. And that just gives us all the options, because whether they were seen the same day or without anything to eat or drink the next day, the surgery happens at the same time. So it ends up being a little bit more convenient in some cases for the patient to have 1 visit rather than 2. In terms of other considerations, the macula status. So is it a macula on retinal detachment? Where we often use vision as a surrogate. So usually if it's dropped below 20/40 or so, even sometimes 20/30, that usually means that there's some fluid within the macula. And then that kind of changes our time scale of when we are trying to get these patients into the surgery. Because if it's macula off, whether it's done on day 0 or 1 week, the outcomes are the same. However, for macula on detachments, we typically try to get them done within 24 to 48 hours. In terms of lens status, this was a 32-year-old patient who happened to be phakic. And so that does play some consideration whether we want to choose vitrectomy or scleral buckle, or sometimes do none of those options. So what are the different options that are available? There's really 4 that would apply in this case. And so what I'll do is I'm going to flip this over to you guys in the chat, and maybe have some of you guys chime in terms of what options, what you might do among these 4 options. So laser to the retinal detachment, so basically seal it up with laser at the edge so that it doesn't advance. He's a young guy, and so often the vitreous is not very liquid and it can hold. Pneumatic retinopexy is sometimes an option. Typically, we like to use it when the tears are either superior or at kind of a cardinal position like 3 or 9, because you can get people to position well. If it's off angle, it's a little bit harder, but it can be done. They just have to kind of crank their neck in a certain position to get that effect. And then finally, you have options of the more traditional surgeries, which are scleral buckle and pars plana vitrectomy. Okay, the success rate for the scleral buckle and pars plana vitrectomy are on the order of about 85 to 90%, so really very good, but not perfect. And that's something that we kind of let patients know in advance of the procedure. So the general gist of this is more invasive as we go down. And so often we will start at the top and work our way down. So in this case, here you can see that same photo, but this is after we've done our handiwork. And so you can see the same bolus fluid that was there before, but you can also see laser markings around it. I'm not sure if you guys can see my pointer or not, but you can see this kind of whitish faint line that's a little further out. And you may ask why it's further out, but that's because even though it looks like a bolus detachment in that area, there's actually a fluid that's really extended beyond that. And you only kind of discover that when you're starting to put laser in. So that's why in orange, you can see the extent of the laser treatment. The patient was then seen about a week later, and we follow these patients very carefully because with laser, it's kind of like glue that has to set. And if I kind of highlight it here, you can see at the bottom, there's a little bit of guttering. There's a little bit of fluid that's kind of broken through this barrier. So think of all these sandbags that have been set up, and then you basically have a little bit of fluid that breaks through. And that does happen, and that happens because when the glue sets, if the fluid kind of breaks through before the glue is set, it kind of moves on. So this is one of those where we tried to, you can kind of feel like a hero because you save somebody from a trip to the operating room if you can get it to laser. And this came super, super close to doing that. But unfortunately, this patient ended up needing the full scleral buckle and the trip to the OR. They're doing excellent now. They're pinholing to 20/40. That was just a week out from surgery. And then typically what we do is we do our retina refraction, which is we turn the lights off and the lights on and off. And as long as they can see light, we send them back to Dr. Howard and we have them do the formal refraction there. So we'll have them go back in usually about a month to 3 months after the scleral buckle to have them get fitted for glasses, as we've made them a lot more nearsighted with that buckle. So with that, I will end and take any questions, and I'll stop sharing my screen.
So Angkor, excellent presentation. So very briefly, and you touched upon it, but what would you tell, so it's been, let's say you put the scleral buckle on this young patient and they're already maybe a high myope, and you put the scleral buckle on and it's been 3 or 4 months now, you're sending them back to the referring optometrist. What would you tell both the optometrist, just in general, sort of big picture, and also what would you tell the patient themselves about what they can expect in the future after their scleral buckle? Travel, myopic shift, things like that, big picture.
Yeah. So, I mean, in terms of the referring doc, we do try to communicate well. We send letters back, and the idea is often we kind of rely on their help, frankly, to get the best possible result, because it does require the added refraction, surveillance, and kind of an awareness that sometimes there is a little bit of creep that can happen with these buckles over time. But typically, if we send them, I like to send them around the 3-month mark, because at that point, when you get a refraction, that's kind of the right prescription. For those patients, I really like a buckle in patients that are young, because it gives you 360-degree support. So if you have support all around the eye, it kind of is, even if you develop a tear in other locations, you kind of have a built-in protection mechanism that's built into the eye. And a lot of times these are very high myopic, nearsighted patients that are prone to developing lattice and tears in these areas. So I think it works really well as a technique, but we tell them constant surveillance is something that we need. But typically, oftentimes we follow them once a year, once they're all said and done from the surgery, and have their eye care provider continue to do their follow-up.
And thank you, Angkor. Tien, are you there? Dr. Wong?
Yes.
Quick question for you, Tien. So is there an age cutoff at which you start to consider vitrectomy more than buccal? Let's assume a patient has one tear and they're 30, 40, 50, or 60, and they're phakic. Is there sort of an age cutoff where you would jump to a vitrectomy versus a buccal, or talk about your thought process in terms of age and buccal versus vitrectomy, assuming one tear or same retina?
Yeah, usually if you see, if I see any vitreous hemorrhage, then that would push me toward vitrectomy. But oftentimes, especially younger patients, even though it's thought to be a tear, it probably is more likely an atrophic hole or just a larger hole. Because you get a horseshoe tear, you pretty much have to have PVD. And in a lot of these cases, in younger patients, they don't have the PVD. It's just basically maybe an irregular shaped break. And so those patients where there is no PVD, I prefer to put a buccal on the eye. And obviously, you can talk to patients. I've had patients who were older, PVD related, with some, a little bit of vitreous hemorrhage, but they weren't bothered by the floaters. If they have to travel, then you would consider putting a buccal. But I think that in general, if it's vitreous detachment related, I typically will consider doing vitrectomy. And if it's more due to abnormal vitreous, abnormal retina, perhaps a long eye, and I typically will support the do a scleral buccal and change the shape of the eye.
Would you ever do a primary vitrectomy, a primary scleral buccal on a pseudophakic patient?
Rare. I don't think I've done a primary vitrectomy, a primary scleral buccal on a pseudophakic patients. And a lot of that goes back to our teaching about aphakic patients and such. And the thing is, when you're pseudophakic, you really had an implant put in that sort of is corrected for your degree of myopia and such. And so when you put a buccal on somebody who's phakic, eventually someday when they have a cataract surgery, they can sort of correct for that. If you've already paid, especially if you paid for a premium multifocal lens or something, an IOL, then you put a buccal on, it changes, it's going to change the refraction. So the other reason for doing the vitrectomy is you're not going to induce cataract in somebody who's already pseudophakic. And it's easier to get all the vitreous off in somebody who's already had the cataract removed. So I feel much more confident that it would be good vitrectomy.
Well, good. Thank you, Dr. Wong. We'll get ready to move on. I think
James?
Yes.
I was going to say about one other thing about buccals is there's one group of patients that really seems to like scleral buccals, which is the 40 to 50-year-old group, where you put a buccal on somebody who's just borderline presbyopic, you give them an extra 1.5 diopters of myopia, and you've basically performed the retina equivalent of monovision. They now have a reading eye if everything works well. And so that group of patients really, I've seen some really outstanding results of, oh my gosh, I can read with this eye now, and I don't need my readers anymore.
Good point. And, Dr. Sue asked the question in the chat, and Dr. Wyckoff answered it, but, the single greatest risk factor for a retinal attachment is a history of one in the other eye. So when all these patients that we're talking about have a retinal attachment, we always are hyper vigilant for the years to come in the other eye. And basically 1 in 6, maybe 1 in 7 will have an attachment or tear in the other eye. So it's important to really, really monitor the contralateral fellow eye when someone's had a retinal attachment in the one eye. And so, Dr. Fish, are you ready to quote jam out here? Jam out or give us a presentation, either one.
That's right. Okay, next slide. This case was sent in by Dr. De La Garza, and we got this image off the image portal, and already you can see in the left eye a lot of subretinal fluid. They come in and we evaluate them. Next slide, please. This is a 45-year-old man who'd had 3 days worth of visual blur. He had hypertension, seasonal allergies, was COVID negative, and his only medicine he said he was taking was atenolol for his hypertension. He was 20/20 in the right eye, 20/40 in the left. Everything about his anterior segment exam was normal. Fundus is normal in the right eye. Next slide. This is the OCT in the right eye, shows a nice vitreomacular adhesion. Next slide. And this is the OCT in the left eye, tons of subretinal fluid. Next slide. This is the angiogram we did in the office, and you can see this little pinpoint leak that just blossoms into this bit of pooling of fluorescein dye into the subretinal space. And all of this is compatible with a diagnosis of central serous retinopathy. And I have to say that of all the cases that we see of central serous retinopathy, you can kind of see on the image on the left the just kind of hint of a smokestack pattern, the pattern of leakage that's classically described in central serous retinopathy. However, in practice, it's kind of a minority of cases that do that little I dream of Jeannie smokestack, appearance. Next slide. So when we do EDI OCT, you can see a thickened choroid in the right eye and also in the left eye. Next slide. And that arrow is a little bit misaligned, but basically showing you the area that we're looking at on the EDI shows a thickened choroid. Next slide. Anyway, central serous retinopathy typically affects males a little more frequently than females. The mean age is around 43. It's idiopathic. It's one of the pachychoroid or thick choroid diseases where you get an anatomically thick and dilated choroid and choriocapillaris. It's really important to take a careful history about medicines. There are lots of things that patients don't consider to be medications. When I asked them about, do you take any medicines? Anybody? No, no, no. But then you start asking, well, what about like some kind of steroid inhaled things? And finally, this patient sort of fessed up to the fact that he used Flonase. So that is a really important historical fact because so many patients with central serous retinopathy have some kind of association with either endogenous or exogenous corticosteroid or even androgen or testosterone use. So lately, within the past 5 to 10 years, there's a whole cottage industry of patients who are diagnosed with low T or low testosterone. They're put on exogenous testosterone replacement, and we've really seen quite an uptick in the number of CSR cases as a result of this. So with CSR, you can get either focal or diffuse leakage or sick RPE kind of picture. This is a very focal area of leakage. And sometimes you can see the RPE damage really well when you get a fundus autofluorescence image. Next slide, please. So the treatment of central serous, really the vast majority of cases, we just say, okay, we come back in 6 to 8 weeks. Many of these cases will just get better all on their own, spontaneous resolution. We do insist that to the extent possible, unless somebody is on steroid for an extremely important reason, that we try to stop all exogenous steroid. In cases that are chronic, photodynamic therapy, PDT, is frequently used and is really successful at sealing up the areas of focal leakage. Occasionally in an area that's leaking kind of off to the side, not even juxtafoveal, but extrafoveal, I will sometimes use a very low energy focal thermal laser. And then in cases that are really challenging, the ones with just lots of leaks, kind of a sick RPE, there's been a lot written about the mineralocorticoid antagonists, eplerenone and spironolactone. I think all of us, it's fair to say, have used these with, I would say our average group batting average is probably no better than about 50%. And in fact, there was a fairly recent paper that showed that at least at one dosage level that eplerenone was not terribly effective for CSR. So I think it's one of those things that I personally only use in cases where I don't really know what else to do. It's not a PDT candidate. It's not a focal laser candidate. There's a lot of diffuse leakage. And it's like, well, we might as well try the eplerenone, but that's almost the only situation that I will try is in a multifocal, diffuse, leaky CSR case that hasn't gotten better after 3, 4, 6 months. And then there's a whole host of other things that have been tried and kind of discarded in the treatment of CSR. But by and large, this just has a very favorable natural history, tends to do fine just with observation. And so the patient comes back and they're a little bit better, and they come back again and they're a lot better. And then we usually turn them back over to their referring doctor. Next slide. I think it's Dr. Wyckoff's turn now. Any questions about CSR or management of that? This is a fairly common condition. We see a lot of this on a day-to-day, week-to-week basis.
So Dr. Fish, very quickly, so, maybe a patient gets referred back to their referring optometrist and they say, you know what, I initially had CSR, CSC, central serous choroidal retinopathy, but wait a minute, you gave this person anti-VEGF after a period of time. Why would that be? In other words, a choroidal neovascular membrane, can that occur on top of or concurrently with central serous retinopathy or choroidal retinopathy?
Absolutely. CNV is not unheard of in chronic cases of CSR, but actually a more common occurrence, which I see probably on average once a month, is a 55-year-old patient comes in and their angiogram pattern and EDI, and you put all the data together, and it's like, is this CSR or is it AMD? And it's really hard to tell in some of those cases where the age is a little too young for AMD and they're a little too old for CSR, and their angiographic leakage pattern is not really a cut and dried either or, it's clear-cut case. So sometimes I will do a therapeutic trial of anti-VEGF just to sort of see, okay, well, it responded, therefore, it must be more of an AMD pattern than a CSR pattern.
And then Dr. Benz, if you're there, or Dr. Fish, either one, we have this Novulus ODOS focal laser, which really overlays the fluorescein angiography. You can put a no-fly zone where you can't shoot the optic nerve, you can't shoot the fovea. How often do you shoot focal? You mentioned focal laser as a treatment for CSR, especially if they have one or two hot spots. And this Novulus laser that we have enables us to sort of get closer into the fovea without shooting it with our shaky hand. How often, Dr. Fish or Dr. Benz, if you're there, do you actually use that?
Well, I'll answer that quickly. So I haven't used the Novulus for central serous specifically. Have had tremendous success using photodynamic therapy in those patients that have fluid after an extended period of time. Very, very successful with that. So I know you've done it several times, James. I don't know if you want to comment on how your patients have done.
I've done it, but it does give you a nice option. If you have a focal single spot or two that's close to the fovea, you can really overlay that FA, and it's almost like playing a computer game, really, where you just pick the spots and sort of titrate the power of your spot to really knock out that leaking spot and hopefully resolve their subretinal fluid. But Matt, Dr. Benz, if they are going to get PDT, and you say, you know what, look, this central serous retinopathy is chronic, it's not going away, you need to undergo photodynamic therapy. What do patients or optometrists need to know about exactly what that is, and what warning signs, symptoms during or after the therapy should they receive?
Sure. So I'll talk a little bit medically and then some non-medical issues that come up. I mean, number one, medically, and this was the treatment that we used for macular degeneration in the past before we had injections of anti-VEGF. And the big issue is that your skin is photosensitive for several days after a treatment. So you'd be exquisitely sensitive to the sun and need to be very aware with long sleeves, gloves, hat. You can't go outside in the summer sun in Texas, or you would have a big problem. I would say another huge issue that we deal with in treating patients with central serous with photodynamic therapy is that it is many times not covered by insurance because it is an off-label treatment. And so we will typically try to attempt to get approval, and you can get approval sometimes from some payers, but patients need to know that there is sometimes an out-of-pocket cost for that. It's not horrendous, and again, we've had such great success with it that most patients do end up pretty pleased with the ultimate result.
Yeah, that's a good point, Matt. That's probably the only situation where I would use focal laser is in somebody in whom PDT was just not a covered. CSR was not a covered diagnosis for PDT, and if the leakage is pretty far away. And I like James's point about using the Novulus laser to really program and titrate a very, very low energy dose, because back before any of PDT, we used to treat a fair number of chronic CSR cases with just focal laser, and it does work pretty well in selected cases. There was a question about recurrence. I think they were asking about recurrence of CSR. One of the things that I'm very picky about is that I really like to see a patient come back even if they feel like they're completely better. I like to see that it's resolved, then I send them away. There is a very, I don't know, I would say 10 to 15% of my CSR chronic cases, they come back a year or two later, but it's not clear to me that they ever resolved. And in order for us to start thinking about, are you a chronic case or are you just a recurrent case that just disappeared? I really like that follow-up visit. Okay, you're better, go back to your referring doctor, and now I consider you done. And yes, there is a fairly high rate of recurrence in some forms of CSR, particularly those multifocal leaks.
All right, Charlie, are you there?
Ready. Let's
All
see
right,
it.
Charlie.
Yeah.
This is the last and final case. Charlie, tell us about bring us home.
Let's do it. Okay. So first of all, Christopher Tram sent in this excellent case. These are sort of challenging images to see, but they're largely challenging because of the pathology in the posterior segment. So what's the first thing you see there? Encore. What's the first thing that jumps out at you?
Yeah, so looking at the left eye, there's this scaphoid-shaped hemorrhage sitting at the bottom.
Blood.
And that's floating throughout.
Yes, big boat-shaped hemorrhage, huge hemorrhage. So what is that until proven otherwise? Tian?
Well, I mean, you look at the other eye, and he's got PDR with vitreous hemorrhage.
Yeah. So we're looking at PDR, bad diabetic retinopathy. Truthfully, we see this all the time, so we kind of become numb to it. But this disease really drives me crazy because this disease is purely a shortcoming of us as physicians. It really is. This disease is totally preventable and totally treatable if you catch this early enough. So great images here of really advanced PDR in the left eye and slightly less advanced PDR in the right eye. So I'm going to go over to my slides. Try to. Okay. Can you see a single slide?
Yes.
Okay. So I put this, thank you. Yes, the man, the cane. They were making fun of me earlier that that's my patient on the top left. So, so I put this up to sort of ask the question, do you know what causes the most blindness in our country, right? What's the big blue bar and what's the teal bar? What's the green bar, right? I'm going to answer some of these, but I'm not going to answer all of them to make you think about it. So the big blue bar is macular degeneration. Technically causes more blindness in our country than everything else combined. What's the red bar? Well, the red bar is what we're talking about, which is diabetic retinopathy and diabetic macular edema combined. And this really does bother me personally because I love research and I love moving this field forward. But this is a disease that is totally preventable from a blindness perspective. It doesn't have to cause blindness if we catch these people early enough. The most comprehensive analysis of the rates of diabetes on our planet was published by the World Health Organization in 2016. And the estimate was that 1 in 12 people on our planet, including kids, have diabetes, right? A staggering number, 8% of the entire world. And some of the key messages that we've repeated for decades as a field, but always were worth reviewing of patients. First of all, even small changes in your blood sugar, blood pressure control can have a huge impact on your risk of progression and risk of getting worse, right? Patients always want to know, well, why do I still need to get these shots, this laser? My blood sugar is well controlled, even though I spent 20 years with a bad A1C. Unfortunately, you can't change the past, but you can change the future, and you can dramatically change your risk if you improve your A1C. So in other words, even if their A1C is 12, don't harp on them and say, oh, it really should be 6 or 7. Small changes make a big difference. Encourage them to go from 12 to 11 and from 10 to 9, because each of those single percentage change is correlated with a 50% decrease in risk of progression. The second point I would make is convince your patients that diabetic retinopathy for all patients with diabetes is a when, not an if problem. Because humans have this tendency to believe it's not going to happen to me, it's only going to happen to everybody else. We need to convince them that this is going to happen to them if they're fortunate to live long enough. Richard, you're one of the best communicators that I know. What are sort of some of your lines with your patients with diabetes?
I mean, it's just, you just have to sort of put things in terms of a long-term perspective. So a patient like this, you have to kind of get their mind wrapped around the fact that the very first thing I tell them is, I cannot cure what you've got. I can treat you, but I can't cure you. And since we're kind of getting into the game late and we're down a few touchdowns, we got a lot of work to do. So we need to get busy with, and then I outline the treatment plan or the research protocol that I think is the best for them. But all of it is going to be a high intensity thing. And then I always give them the cancer chemotherapy analogy, which is, if you walked into an oncologist's office with a case of lymphoma or some cancer, you have to be prepared for ongoing multiple sessions of chemo or radiation or whatever. And in a similar fashion, a patient with diabetes who's got advanced retinopathy is going to have to strap in for a treatment protocol that's not a 1 or 2 or 5. It's a monthly until stable and treat and extend. And if we're lucky, by the 2nd or 3rd year, you're coming in 4 or 5 times a year, and that's it. But for the first year or 2, it's a pretty intense treatment program.
Yeah, great comments. Thank you. So, one of the biggest challenges that we all face is this lack of screening and the lack of follow-up, right? So many patients with diabetes don't receive the screening that they need and the screening that they deserve and the early treatment that they would benefit from. Matt, you're an incredibly efficient person, also very well spoken. What do you communicate to your patients with diabetes that don't have end-stage diabetic retinopathy, but more the earlier stages before you want to intervene?
So I would look at any time I see a patient who comes to me with any degree of diabetic retinopathy, I look at that as an opportunity to talk to them and to teach them, and to hopefully, establish a bit of a rapport with them before we do that. But it's every chance you see them, it's a chance to teach them and to get them to learn a little bit more about, good glycemic control over long periods of time will help them, not only with their eyes, but with everything else.
Great comments. Okay, so here's the new patient that we see all the time, right? And what's interesting about this patient with diabetes to me in my clinic was the posterior pole, the macula looks pretty clean, right? There's not much hemorrhage back there. There's a few, but then you look out in the periphery and you start to see these areas of hemorrhage. And Alan asked a great question earlier, I think it was in the chat, about wide field imaging. And man, wide field imaging, I think for all of us on the call here, is indispensable to our practice. And then Matt Benz and Encore and others made the point that during COVID especially, wide field imaging has been super valuable for efficiency, for documentation, and for the challenges because of examining eyes with masks and contact precautions and all that. So what do you see out here in the periphery? Any of my colleagues on the line want to take a stab at what we would call this? James, maybe I'll turn the table. You've been picking on everybody else. Maybe I'll pick on you. What do you see?
I'm here. Yeah, so you see some so only in the, there's some dot blot hemorrhages in the superior nasal quadrant, sort of over here, but in the where you're circled in red, there's all these little dot blot hemorrhages way out in the periphery. But like you said, in their central field, it looks pretty clean.
Yeah, exactly right. And so we think of these as what are called PPLs. It's the new term that's used a lot in the literature, predominantly peripheral lesions. This is the case in diabetes when over 50% of the lesions, most commonly hemorrhages, are located out in the periphery versus inside of these white little outlines. And if any quadrant has an area of PPL, then the entire eye is designated as PPL. And the reason this is important—
Charlie?
Yeah, Richard.
I want to interrupt something just because I don't want you to leave this slide without pointing out. Please point out with your pointer, infratemporal, there are these little areas of kind of white fibrotic something. That's
Great.
Something that even in y'all's offices, when you see that on an Optomap picture, you should be highly, highly suspicious that this is not just a bunch of dot blot hemorrhages, that you've got proliferative disease. I didn't want you to advance past that slide without mentioning.
Exactly right. This is neovascularization elsewhere. And what's interesting is that in the original ETDRS papers, this eye would have been described as probably mild NPDR because there's no NV within the 7 standard fields. But there is NV outside of the 7 standard fields. Very interesting. Great observation, Richard. The reason these PPLs are important, to make a long story short, is that eyes with PPL have a much higher rate of progression to proliferative disease, of vision loss, and of diabetic retinopathy severity worsening. There's prospective data also showing that a substantial proportion of eyes will have PPL. Between 10 and 50% of eyes with diabetic retinopathy will have PPLs. Okay, let's talk about treatment of diabetic retinopathy. So there are obvious thresholds that we all would initiate treatment, right? Center involved fluid with vision loss, high risk proliferative disease. But the one that the field is currently grappling with is this. These are the asymptomatic, what we call high risk eyes with NPDR. We know that if you treat these eyes with anti-VEGF agents, you can make these hemorrhages and neovascularization really shrivel up and go away. Here's more of these white points that Richard was talking about, Dr. Fish showing areas of NVE that have regressed, remarkable effects of our drugs. So the question is, do you treat these patients? And one research point I would bring up is that we have a very interesting study going on right now looking at pills for diabetic retinopathy, which I'm actually very excited for. We've looked at a lot of oral medications before. This one is actually a derivative of cannabis or marijuana. It's not the active ingredient, so it doesn't make patients high, but it does, we think, improve their vasculature. And so we're studying this in a large trial currently. Very exciting opportunity for patients and would be great for the field. The best data we have on the value of early treatment in these patients is the Panorama phase 3 trial, which Dave and I have been involved with from the beginning. And this is the core data showing on the left that without treatment, these eyes have about a 60% rate of progression to PDR or DME within 2 years, and you reduce that by 70 to 80% with active anti-VEGF dosing. And the last slide I would leave you with is a point that Dave brought up. He and I are both extremely excited about this, as we all are at RCH, is this future of gene therapy. This is being studied in wet AMD, being studied in diabetic retinopathy, DME, RVO, all of our exudative diseases. There are many challenges that lay ahead before today and the FDA approval of these medications to treat these diseases, but it's an incredibly exciting time. And it is such an honor to be able to offer these treatments to our patients. We have multiple trials right now in all of these diseases looking at gene therapy. And it's great to be able to offer next generation treatments to the patients that you guys trust our care with. So with that, I'll hand it back over to James.
Wow, Charlie, super exciting. And it's all come full circle. We heard Dave at the beginning talk about gene therapy and longer acting anti-VEGF drugs. And then we sort of threw it out there a little bit about DME and diabetic retinopathy, and that's coming for that disease entity also, hopefully, in terms of research trials. So Dr. Chin, are you there?
I'm here.
Okay, Eric, I got a question for you, and just a general management question. Let's say a patient like Dr. Wyckoff just showed has severe non-proliferative diabetic retinopathy in both eyes, and you feel good about their compliance. You say, Mrs. Johnson, this is what you have. And she says, you know what, Dr. Chin, I will come back when you tell me to come back. What would be, number one, she doesn't have any diabetic really macular edema. Her vision is good. Let's say it's 20/20, 20/25, and she's in her 60s or 70s. She's had diabetes for a long period of time. Would you initiate treatment, number one? And how often would you give her anti-VEGF, assuming she's just sort of cruising along, but she stands at the threshold of severe non-proliferative diabetic retinopathy upon overreaching into proliferative diabetic retinopathy?
That's a great question, James. I think we do see certainly patients that have severe diabetic disease, and they may be asymptomatic like you described. I mean, maybe they have good vision, 20/20, 20/25. A lot of my treatment decision as far as whether to treat those patients would be sort of fluorescein based. I'll get a fluorescein, and depending on how their perfusion status is. And so if they have a lot of non-perfusion, or if they have sort of a lot of leakage out in the periphery, even though they have very good vision, and if I think they're high risk for converting over to PDR, I might be more apt to treat them with anti-VEGF. And usually a lot of times those fluoresceins and the photos that we have are very, very good for patient education as well, because if they're asymptomatic and then you show them their fluorescein that, may look just fine or may look very bad, that can help them make a good decision as far as what they want to do as well.
And Dr. Benz, same question. What is your sort of threshold for initiating treatment, and roughly how often on someone with severe non-proliferative diabetic retinopathy with no DME, no PDR yet, but they seem to be headed in that direction?
I'll make a couple of comments with respect to this. Number one is that I think myself and others in general, we're trending more towards treating a little earlier in diabetic retinopathy in the disease state, is because of the tremendous results that you can see. I don't have any real formal cutoffs. I would also say that with these patients, it's not necessarily as urgent to treat them versus a patient that's got a proliferative diabetic retinopathy. And you may be able to have a visit or two with them to kind of start that conversation about how important this is. I might mention the fact that these injections exist and bring that up to them. Maybe a visit before we institute it, so they don't come in to me and the first time that I see them, I'm immediately leaning them back and injecting a medication into their eye. So it's something that we can work with the patient over a period of time.
So that's a good idea. You want to let them marinate a little bit on the idea of the possibility of needing anti-VEGF in the future, especially if their hemoglobin A1C, et cetera, is not under control and
sure,
and this is coming down the pike for them, so to speak.
Mm-hmm. Get them used to the idea before it happens.
Preemptive strike is always good. Well, thank you, Charlie. Thank you, all our panelists. Can we go to the next slide here? I think we've wrapped it up. So number one, thank you very much for participating in this Retina Consultants of Houston virtual CE. I thought it was a really great success. I learned a lot and hope you did too. To complete your registration, you get one therapeutic hour. So any questions, contact RCH Doctors at HoustonRetina.com. And basically we have 2 upcoming courses, and they're essentially 1 per month. And there'll be something similar to this, obviously, in this COVID era, CE virtual Zooms. One is Thursday, September 10th, 7 to 8, same time frame. So mark your calendars. And the one after that is about a month later, October 14th, 7 to 8. So number one, please also don't forget, register in the chat box with that link for the HIPAA compliant back and forth referral system. The virtual referral system is fantastic. The link is there. It's very quick and easy, and we can talk back and forth in a HIPAA compliant manner that's really, really excels what we can do for our patients together as we work together. And so any questions, please contact Sarah. And any other questions there? Anything I missed?
You're good.
C is there. Excellent. Sarah says I'm good. Thank you, RCH Doctors. Everyone stay safe in this COVID era. We look forward to seeing you virtually on Thursday, September 10th. Thank you so much.